Good evening, good afternoon, and welcome everyone to our webinar on high-yield EKGs for the USMLE and COMLEX. We're so glad that you've joined us today. My name is Moses. I am an internal medicine resident as well as a tutor with MST, and I'm really excited to share some high-yield topics for you today. I'm joined by my colleague, David. David, would you mind introducing yourself to the audience?
Hey everyone, so I'm David. I'm a MS4 at University of Texas Medical Branch in Galveston, and I've been with MST for about half a year now. I tutor for STEP in level 1 and then STEP in level 2. And I'm really excited to be joining Moses for this high yield seminar on EKGs.
Amazing. Before we dive right into things, I just wanted to spend a few moments orienting you all to who we are at MST. If you haven't heard of us already, we are a collection of trainees as well as attendings who are passionate about teaching, passionate about coaching, and we provide both one-on-one online tutoring, webinars like the one that you're in right now, as well as advising and coaching really about anything that involves your journey through medicine from application to med school all the way out, as you can see, to the boards. We've been working with students for a long time. We've really been privileged to be a part of a lot of people's success. And I hope, as you can see from this webinar, we're a little bit nerdy. We love to teach, and we'd love to have you contact us if at any time you would like a personalized touch to help you along your journey. A few words just before we get started. I have two monitors, so if you see me looking to the side, I'm looking at the chat. We will attempt to answer questions along the way in the chat, but fear not, if we don't get to you while we're talking, because we have so much good material to cover, there will be a Q&A session at the end. So please put your question again in the chat at the very end so that we can get your questions answered. Speaking of an agenda, really a roadmap for tonight involves taking a big picture view of cardiac conduction, and we will teach you a systematic way to read EKG, some simple steps. But really, it's all about the reps. We want you all to be active in testing your knowledge on commonly tested arrhythmias and other abnormalities that can be found on EKGs. We have a lot of practice for you. So time permitting, we'll have some additional practice for you as well. And we'll wrap up again talking about MST. So please be active in the chat. We will prompt you to really put your thoughts out there, because again, the more you flex that mental muscle, the more this knowledge will really become second nature for you. With that, David, tell us about the 5 steps to EKG reading.
Sure. So when you see an EKG on the exam, it's important that you don't just wing it. You need to have an approach, like an algorithm that you kind of go through to see what could be going on with the EKG. So what we usually recommend is taking or kind of like taking a 5-step approach, starting with the rate, like, how fast is the heart beating? Rate, then the rhythm, is this atrial fibrillation? Is it flutter? Is it, VTach, VFib? Is it a sinus rhythm? Stuff like that. We'll talk about that. The axis is like the overall kind of net direction in which the depolarization wave is traveling. That can be helpful for kind of giving you information about left ventricular hypertrophy, right ventricular hypertrophy, or if the axis is normal, that can be reassuring. We'll go through that as well. Intervals. So intervals are going to be a crucial part of assessing an EKG. This is going to be things like the PR interval, which can be affected by heart blocks, which we'll talk about later. The ST segment, or the ST interval. That can be affected by things, pericarditis or ischemia. We'll get to talk about that as well. And then the QT interval, which we'll also talk about. And then the morphology. The morphology kind of refers to is there anything important here or significant here which can help us establish a certain diagnosis? Maybe we have, this would include things like ST changes. Could be the delta waves, which we'll talk about, but lots of kind of interesting stuff that could happen here, which could kind of clue you in as to what could be going on and could lead you to the right answer. So yes, we usually start with the rate, since that's the kind of easiest to establish. Once you have the rate, that should help you to narrow down your differential, and then you can use each of the additional steps to further narrow down your differential until you have the right answer on the exam.
Wonderful. And so we're really going to go through each of these in detail, starting with the rate. Big picture, again, when you get to your exam, heart's pounding a little bit, maybe you have a bit of a tachycardia. The first step is asking, is the rate too fast? Is the rate too slow? Or is the rate just fine, the Goldilocks rate? And there are ways for us to be quantitative about this. So there's the 300 rule, where you take the number 300 and you divide it by the number of big boxes that are between the QRS complexes. And that can give you the rate. So if we do that on this ECG, you'll note that it's variable. So if we look at this interval here between these two QRS complexes, we have 1, 2, 3, 4, 5. But then if you look at the next interval, you see 1, 2, 3. So if we believe this complex here that I'm circling, you would maybe think that it's something like 100. 300 divided by 1, 2, 3. However, if we pick these two QRS complexes, you might be led to think that this is a slower heart rate, maybe closer to 75. So you can be led astray if the rhythm, which we'll talk about in a little bit, is irregular, because you're not sure which QRS complexes are you going to be doing the box counting process. So when that fails, or when you have an irregular rhythm, you can count up the number of QRS complexes and divide them, multiply them by 6. And so in this case, it comes out to the high 70s roughly, which you would do in this case because there's a bit of irregularity to it, by taking the total number of QRS complexes and multiplying by 6. But again, big picture, too fast, just right, too slow, couple of different methods you can use to arrive at that answer. Because ultimately for the exam, it probably doesn't matter if the rate is 80 versus 90, right? Or if it's 50 versus 45. It's about putting yourself in a bucket. So just as David said, you can get closer to the diagnosis, closer to answering the actual question that is being asked of you in any given vignette. So the first up, we have rate. Next, we have rhythm. Take it away, David.
Sure. So once you have the rate established, then you want to figure out like what is the overall pattern of the EKG? Like what is the what type of morphology is present in the EKG? So usually the lead that we recommend starting with here is lead 2, because in lead 2, this is going to give you your best view of the P wave, assuming that you have a normal P wave. Remember, like in the cardiac conduction system, the signal is like starting in the SA node, and then it's kind of traveling through the atria, through the right atrium, down to the AV node, and then down into the His-Purkinje system in the ventricles. So if we have a normal sinus rhythm, or what's called a sinus rhythm, that means that our conduction system is starting where it should be, in the SA node. That P wave should be positive if we have sinus rhythm. So now, that a P wave alone does not establish a sinus rhythm, though. If you're going to be in sinus rhythm, you want to have a P wave followed by a QRS complex. So P wave, QRS complex, you're always going to have that with normal sinus rhythm. That will tell you that the patient is in your normal sinus rhythm, and that will be a normal finding on EKG. So starting with rhythm, starting with lead 2. That'll kind of tell you, like give you an idea of what the rhythm is. Like if you maybe you won't see a P wave. Maybe you're just going to see like a bunch of QRS complexes. Maybe you're going to have like a totally erratic rhythm, and so it's not going to be clear what's going on. But if you see that P wave followed by a QRS complex in lead 2, that's going to clue you in that this is a sinus rhythm. So yeah, we usually recommend starting there, and then and if you can't really figure out what the rhythm is based on lead 2. You might look at AVR, kind of looking for that kind of biphasic P wave. You can see that classically in sinus rhythm. And then also usually in a 12-lead EKG, at the very bottom of the EKG, you'll get what's called a rhythm strip. Like this is where they run a certain lead, like usually lead 2, for the full 10 seconds. And so that can give you a full kind of portrait of what the rhythm could be. So like usually start with lead 2, see if you're in sinus rhythm. If you're in sinus rhythm, see like what other clues you can gather to establish the rhythm. And if you still can't get the rhythm, then go to your rhythm strip at the bottom if they have it, and then see if you can figure out what's going on. Anything to add to that, Moses?
I love it. The phrase that I was taught as a medical student was a P for every QRS complex, a QRS complex for every P, and you want that P upright in lead 2, so you know that atrial activity is coming from the right spot, or at least our best guess that it's coming from the right spot within the atria. That was beautifully said. Next is something that I think confuses and intimidates a lot of students, which is the axis. But we're going to keep this really simple because you've got to get to the right answer on an examination, right? And that is the axis. And David already gave us a sneak peek here by saying that it's the general net direction of electrical activity in the heart. So remember that the signal starts in the atria, right in the right atrium, at the SA node, and then it travels through the atria. It pauses briefly at the AV node. It goes down into the ventricles and depolarizes the whole ventricle so that you get a concerted contraction leading to your cardiac output. Well, if that's true, and you can imagine in your mind's eye where the various leads are placed, you can imagine that the net vector should sort of go down. That makes sense, atria to ventricle, and it should point in the direction of how the heart anatomically sits in the heart. So to make this simple, a normal axis is in the green here, and you figure this out by looking at 3 leads. Really 2, but for a complete picture, you can look at 3. So if lead 1 is positive, that means the net direction is towards the right. And that would be normal, right of the screen here. And if AVF is positive, that means on the screen and on the graph of this heart, it's going down. So if both 1 and AVF are positive, you're in this quadrant, this green quadrant that indicates a normal net direction of electrical activity in the heart. But notice that there's variation amongst humans, both in how the heart sits anatomically and in the axis, the resulting axis, such that even up to -30 degrees, that could be normal. And that's where you can start looking at lead 2. If 1, 2, and AVF are positive, for sure, you're in the right axis. We'll get later into what happens physiologically when you end up in extreme axis deviation or left axis deviation. The quick sneak peek here is that it sometimes relates to the mass of the heart. If the mass of the heart is distributed abnormally or there's too much of it, like in hypertrophy sorts of situations, the net direction of electricity can become abnormal. And that can be one of the diagnostic clues that that's what's going on. David, anything to add?
No, that was perfect.
Awesome. Next, intervals.
Okay, intervals. So we already mentioned some of the intervals earlier that you need to know. There's the PR interval, which is the distance between the start of the P wave, which corresponds to atrial depolarization, and the start of the QRS complex, which corresponds to ventricular depolarization. So a normal PR interval is going to be 3 to 5 little boxes on the EKG. A little box is 40 milliseconds. And so typically the PR interval is going to be like 120 to 200 milliseconds. So if we have a long PR interval, that's going to be like usually, that's going to be like first degree heart block or some sort of blockage. But what that's going to indicate is that there's some sort of conduction problem between the atria and the ventricles, usually. So that's one interval you want to be on the lookout for. Another one that we like to look at is the QT interval, the QT interval. This is the distance between the start of the QRS complex, or ventricular depolarization, and the end of the T wave, or ventricular repolarization. Now, there's a very helpful little clue here, which can kind of tell you like whether the QT interval may be prolonged. So your clue here is the first thing you're going to do is you're going to look, assuming that the QRS complexes are occurring, they're occurring uniformly. You're going to measure, or you're going to get a rough idea of what your R to R interval is, like like how widely spaced are your QRS complexes. If the QT interval is greater than 1/2 of your RR interval, that's a clue that the patient has a prolonged QT interval. The precise numbers are probably not going to be tested. Like usually a QT greater than 500 milliseconds is considered long for most patients, or for all patients actually. But on the exam, if you can use this RR interval, like this 1/2 of the RR interval rule, that can be a very helpful clue for establishing a long QT interval. This can be caused by things like drugs. It can be genetic in some cases. Now, we worry about a long QT interval because it can degenerate into a certain potentially deadly arrhythmia. What is that arrhythmia?
Please go ahead and put your thoughts in the chat. This is the active part of the webinar. Wonderful. I'm seeing torsade in the chat, and VT as well.
You know, that's interesting because VT is actually not an incorrect answer. So the correct answer I was going for was torsade. Torsade de pointes comes from the French, means kind of twisting of the points. It's where you have this it's like almost like the rhythm strip has been kind of twisted about the bass line. So you get this like very kind of erratic pattern which kind of like oscillates or undulates. It's a very bad rhythm to see. You do not want that's bad news. And so that is a type of polymorphic ventricular tachycardia. So sometimes they'll get you on exams because the patient's clearly going to have torsade on their EKG, but you're going to look down to the answer choices and you're not going to see torsade. That's because the correct answer choice is polymorphic ventricular tachycardia, not monomorphic, polymorphic. So be on the lookout for that.
Beautiful. And that was a perfect pearl, David, because I think folks shouldn't get bogged down in trying to figure out what exactly the QT is as a number on the exam. Your point about longer than halfway between two QRS complexes, and specifically the R waves, that is absolutely on point. This is an example where this appears just to the eye, eyeballing it. It looks a bit long. That's absolutely right. Next, we get to morphology. And again, here, if you wanted to be a little bit artistic, you could imagine that the EKG is almost like a painting. And here we're looking at the curves, the various segments, and whether they're displaced from their normal position, right? The big one that you really want to not miss on the exam, and it's critical not to miss it for a patient, is abnormalities of the ST segment. And that's because when the heart is starved for oxygen, for nutrients, perhaps commonly as happens with a myocardial infarction, you really want to pick that up because interventions can be life-saving. So again, focusing here on the ST segments in the chat. Go ahead, where are you all seeing any abnormality in the morphology of this particular part of the EKG? I have someone already pointing out that this is a STEMI, perfect. Another person is pointing out that you're seeing some of that in lead 2, you're seeing some of that in lead 3. My goodness, folks are advanced and even pointing out the fact that you can get a sense of which vessel is impacted by an infarction based on the pattern of ST elevations. And you're absolutely right. This is an inferior myocardial infarction. You see those elevations in 2, 3, and AVF, just to throw some things out there. You can see reciprocal changes in leads that mirror, right, the pattern of infarction. Other things to look out for would be things like Q waves, things like T wave inversions as a person evolves, as the EKG evolves through the physiology of a myocardial infarction. But of course, you can also have ST depressions that can happen in a variety of situations. You can have extra little wiggles and squiggles along, which we'll highlight in additional EKGs. But the big one here is not missing a myocardial infarction.
Sorry, if I could just add one kind of common,
please do.
One common question that's asked on exams is, for patients with this particular pattern of myocardial infarction or this particular location, there's a certain drug class that you want to be very, very cautious in using. What is that drug class? And this is a drug class. It's a cardiac drug class that we use for patients with coronary artery disease or acute coronary syndrome. Looks like we're seeing some correct answers here. Okay. Yes, excellent. Yeah, I see. We're seeing nitrates, calcium channel blockers. Not so much calcium channel blockers, nitrates for sure. Because like if you see ST elevations in leads 2, 3, and AVF, that's going to correspond to a right ventricular infarct. And so in that case, instead of like giving a nitrate and dropping your preload, which could precipitate kind of bad hypotension, maybe even shock. You want to give fluids and you want to avoid nitrates for that sort of thing. So do be aware of the specific location of the MI that can influence your management of the patient.
Wonderful. Yeah, that's a trap that you really don't want to fall for. We're going to transition now to giving you a framework for tachyarrhythmias and then give you some examples. David, take it away.
Sure. So if once you've established that a patient has a tachycardia, like heart rate greater than 100, you're dealing with a tachycardia of some sort. The next thing you want to do is you want to look at how wide the QRS complexes are. This is going to help you to further narrow down your differential. If a typical QRS complex is 2 to 2.5 2 to 2.5 of those tiny boxes, so like around like 80 to 100 milliseconds long. If the QRS complex is longer than that, like if it's like 4 little boxes, if it's an entire kind of big box, that means that you have a wide QRS complex. So starting with narrow QRS complex tachycardias, and like once you've established that you're dealing with a narrow QRS complex tachycardia, you then want to ask, okay, is the rhythm, is it regular, or is it occurring kind of uniformly in a regular pattern, or is it irregular, or is it occurring kind of like erratically, kind of out of order? If it's regular, there are a few things you want to consider. One of them is sinus tachycardia. This is simply like normal sinus rhythm, but in tachycardia now. Often could be due to things like, fevers, infections, could be like hypovolemia, stuff like that. Supraventricular tachycardias, or SVTs. These, by definition, a supraventricular tachycardia is any tachycardia which originates above the level of the ventricles. So that's usually going to mean the atria or the AV node. And so oftentimes on exams, when you see an SVT, they're not going to give you P waves. Like the heart rate is going to be so fast that you're not going to have sufficient space to be able to visualize the P waves. So if you see a narrow QRS tachycardia, which is regular, and there are no P waves, you definitely need to consider a supraventricular tachycardia of some sort. Other examples there would be things like AVRT, AVNRT, and A flutter is also considered a supraventricular tachycardia. The specific differential is a little kind of too broad for the exam. Like things like AVRT, AVNRT don't really need to be able to differentiate those for your exam, but it is good to be aware that if you see like a tachycardia with no P waves that's regular and has narrow QRS complexes, you need to be thinking a supraventricular tachycardia of some sort. Okay, moving on to the irregulars now. We'll talk about some of these in a little more detail later on. But atrial fibrillation, that usually has narrow QRS complexes, but it's going to be irregular. It's not going to be regular, right? It's going to be kind of chaotic. There's going to be no pattern. It's what we call an irregular rhythm. There's no pattern whatsoever to how the QRS complexes kind of march along or how they originate. There's multifocal atrial tachycardia. The vast majority of the time, this is going to be due to lung disease, especially COPD. What you see here, we'll show some examples later. But like you have 3 or more different P wave morphologies. Like you actually do have P waves in this case. In distinction to AFib, where you don't have P waves, you actually do have P waves here, but they look different each time. So that's going to be your clue for multifocal atrial tachycardia. And then A flutter with variable conduction, which is a little advanced, something you may see in the wards, probably not going to see on your exam. Now, that's the narrow side of things. Going over to the wide side of things. Once again, like some of these differentials probably not going to be tested, but some you definitely do need to know. What you're most worried about here, both on the exam and in real life, is going to be ventricular tachycardia. That is going to have a regular rhythm and it's going to have a wide QRS complex. This is going to look kind of like large saw blades or shark teeth. We'll show you some examples. It's really concerning. And so good to be aware of. We'll make sure you can identify that before by the time we finish. So your main differential for ventricular tachycardia is going to be something called SVT with aberrancy. Now, SVTs, like we already mentioned, SVTs. SVTs are tachycardias that originate above the level of the ventricles. Think about it this way: if a patient has a bundle branch block, that causes a wide QRS complex, right? So if the patient has a bundle branch block and they have something like sinus tachycardia or they have atrial fibrillation, it makes sense that would cause a tachycardia with a wide QRS complex. That is usually less serious than VTAC, but it's kind of confusing because it can resemble VTAC. Maybe for like step 2 and level 2, you should be able to differentiate those. Probably not an issue for the level 1 or step 1, but we can maybe get into that in more detail later on. Then if we have a wide QRS complex and we have an irregular rhythm, this probably going to be pretty rare on the exam. But like you would want to consider things like atrial fibrillation, which we already said is irregular, with a bundle branch block, or maybe even torsade, stuff like that. But usually not going to be tested. So yes, like tachycardia, like does the patient have a tachycardia? If they do, figure out like, okay, is this narrow QRS or wide QRS? And then is it regular or regular? It's going to help you narrow down your differential diagnosis. Anything I missed there, Moses?
No, that was perfect. And really, practice is king. So we're going to rapid fire go through a bunch of different examples, starting with something that we alluded to a little bit earlier, which is these two examples. And these are two different flavors of essentially the same thing. So we've given you a little bit of history, just like you would on a vignette. Take a moment, glance at these EKGs and rhythm strips, and in the chat, what is going through your mind? What diagnosis is suggested by the top left EKG? And as the results are coming in, I'll quickly run through our schema. So this is fast, it's a tachycardia. It's wide complex. I'm not seeing any P waves, right? And then we have this very suggestive history. And as folks are pointing out, what we see here is torsades, which David already gave us a beautiful description of and the etymology of the word. And the bottom, we have ventricular tachycardia. Notice that there is something sort of regular about it. There's a pattern that is evident on these strips. And the differences sometimes come from the underlying physiology. So a monomorphic, like the bottom, a monomorphic ventricular tachycardia, maybe there's an electrical signal that's going around a scar, perhaps after myocardial infarction, and that's driving a monomorphic VT, versus torsades, which might be something more related to a long QT, for instance, and then an inciting event for a torsade sort of picture. And I just want to put both ventricular tachycardia and ventricular fibrillation side by side, because often students ask me, how do I tell the difference between the two? And remember that I said that there was something sort of regular about the ventricular tachycardia. Again, you're sort of traveling, the electricity is traveling around a scar, or there's some pattern to the way and regularity to the way ventricular tachycardia looks. Granted, sometimes the size, the amplitude of the wave isn't quite constant as it is in torsades, but your eye can clearly pick up a pattern. In ventricular fibrillation, this is terrible because the heart has no underlying organizing rhythm. It's just quivering in place, and there's no sort of pattern to how things are going. It's similar. The way I describe it is, think of it as AFib of the ventricles. It's just quivering, right? There's no discernible pattern. Often the baseline is a little bit erratic. I just want to sear this into your memory, the difference between ventricular tachycardia and fibrillation, although really by ACLS guidelines, they're treated in sort of similar ways. Really good CPR, you want to defibrillate, give them some medications to hopefully restore a more normal rhythm and a more normal perfusing rhythm. Anything to add here, David?
Nope, nailed it.
All right, taking it away. Another example of tachycardia.
All right, so as we said earlier, when you're approaching an EKG, like even if it's obvious what the EKG is showing, you still want to take an algorithmic, like you want to practice using your algorithmic approach to ensure that you're taking a logical kind of step-by-step way of figuring out each EKG that you see on your exam. So first we want to ask, what is the rate? What is the rate of this EKG? And well, so the QRS complexes look pretty regular. So I think we can use our 300 rule. And so it looks to me like there are about like maybe like, I don't know, maybe like 3.5 to 4 big boxes between the R intervals. So that would give a rate of somewhere around 70, 80, excellent. Yeah, you see me all, you're commenting at 75, 80, somewhere in that range. Excellent. So we don't even have a tachycardia. This is a normal heart rate. Okay, now we go to rhythm. So usually with rhythm, you want to start with rhythm, like if they give you a rhythm strip at the bottom, you want to start there, since that'll give you like a full kind of like uninterrupted 10 seconds to look at the rhythm. But like in this case, if there's something that really kind of stands out to you when you first look at, like when you do a kind of panoramic view of the EKG, I would start there. In this case, I'm looking at leads, 2, 3, AVF, and I'm seeing something very distinctive. So we're seeing some like a sort of kind of sawtooth pattern. And so this is virtually pathognomonic for what diagnosis? Okay, Okay, so I'm seeing AFib, I'm seeing VTAC, I'm seeing a flutter. Okay, so the correct answer in this case is a flutter. This is a flutter. So if it were VTAC, remember VTAC, it's ventricular tachycardia. It's coming from the ventricles. And so like if it's monomorphic VTAC, then all of the kind of depolarization waves you're going to see on the EKG are going to look pretty uniform. They're going to look pretty similar. In this case, we notice that like we have some kind of sawtooth like P waves, which are smaller than the QRS complexes. That kind of clues us in that this is not ventricular tachycardia. So like, yes, this is a very kind of classic textbook appearance of atrial flutter. Now we would call this it's like atrial flutter. You usually have a reentrant circuit around the tricuspid valve in the right atrium, and then some of those signals will make it through to the ventricles, and so oftentimes will cause tachycardia, but in this case it did not. Now here's a commonly tested question. So we definitely need anticoagulation for atrial fibrillation if the patient has a sufficiently high of Chad's VAS score. If they have a risk factor for a thromboembolus and in atrial fibrillation, we do want to anticoagulate them. Do we need to anticoagulate patients with atrial fibrillation? Yeah, okay, I see yes. I see if the Chad VAS is high enough. I see yes. I see preferably. Okay. Yes, it seems like there seems to be pretty universal agreement that the answer is yes. Atrial fibrillation is just as much a risk factor for thrombus and embolus formation, or kind of like thrombus formation, and then dislodgement as atrial fibrillation is. So yes, if the patient has a sufficiently high Chad's VAS score, usually a 2 or higher, then you are going to anticoagulate them. Don't fall for that on the exam.
Wonderful. And the only other pearl I'd add is a confusing point, 4-to-1 block. The reason it's 4-to-1, even though we see 3 flutter waves between QRS complexes, is because the atria, that electrical signal is going on in the background, regardless of what the ventricles are doing, regardless of whether the ventricles are contracting or not, that circuit is ongoing. So there is, one way to think about it is that there is another atrial flutter wave that's hiding beneath the QRS complex. And that's why we call it 4-to-1 in this case. All right, moving on. This is not technically a tachycardia, but it's something that could degenerate or evolve into a tachycardia. And you won't always get bright red arrows on your EKGs, but here it's pointing out a morphology and abnormality of the PR segment. What are folks seeing there? Yes, I'm seeing in the chat both the description of what the arrow is pointing to and the disease that it suggests. And that's exactly right. It's a little bit easier to see it here in lead V6 in this arrow here. What you're seeing is a slurring or a change in the slope, initially a little less steep and then far more steep as you get into the QRS proper. And that is the delta wave that is suggestive of something like Wolff, Parkinson, White. And here's the clinical pearl. What if you see someone and they're in a tachycardia? You're tempted to give them something to slow their heart rate. Maybe they're a little hypotensive, and you reach for that tried and true beta blocker. Let's say I want to give metoprolol. Is that a good idea? Chat, what do you think? Yeah, not a good idea. And folks are already putting in the chat what you would actually give, preferably as first line, would be something like procainamide. Absolutely. This is a common one that you don't want to be tripped up by on the exam, particularly if folks have WPW and atrial fibrillation, because it's so reflexive to turn to beta blockers and rate control in atrial fibrillation, not if there's a baseline delta wave, not if there is the concern for underlying Wolff, Parkinson, White syndrome. Wonderful. Bradyarrhythmias.
Yeah, bradyarrhythmias. Okay, so we talked about tachyarrhythmias. Tachyarrhythmias, heart rate greater than 100. Now we come to the slow side of things. So heart rate less than 60. On your exams, step or level exams, if you have a some sort of bradyarrhythmia or a bradycardia, it's going to be one of two things. Either it's going to be sinus bradycardia, So it's going to be like a normal sinus rhythm, just a really kind of slow one, or it's going to be a heart block of some sort, a heart block. Now, we distinguish between three main types of heart block. There's first degree block. This is where you simply have a prolongation of the PR interval. Remember that the PR interval kind of signifies the amount of time that is kind of occurring between atrial depolarization and ventricular depolarization. It's like, how well is the AV node slowing down that signal to allow for the ventricles to fill up with blood before systole. If you have an isolated prolonged PR interval, we call that first degree AV block. Usually does not cause any problems, no major risk of cardiovascular morbidity, mortality. Usually you're going to leave it alone, no treatment necessary. Then we come to second degree blocks. These are a little more serious. And these can be really tricky to identify on tests. So there are two main types of second degree blocks, Mobitz type 1 and type 2. In Mobitz type 1, what basically happens is like you have some sort of issue with the AV node where it's like the AV node, it's kind of tired of working and it gets exhausted. And so initially the PR interval may be normal, but then like the next beat, like the next heart cycle, the PR interval is going to prolong, then it'll get longer and then even longer until eventually a QRS interval is dropped, and you just have a lonely P wave sitting all by itself. So it's like the AV node was like, okay, I'll conduct the signal, but then after a certain amount of time, it's just going to have it and it gives up, and so we drop a QRS complex. This too is not usually concerning. It can be symptomatic. You can treat it if you have to, but usually you don't need to treat it. You can leave it alone. And we'll show you some examples in a little bit. Second degree or type 2 second degree AV block is much more concerning. This can degenerate into third degree heart block or even asystole in some cases. This is where the AV node is not just kind of lazy or kind of tired. It's really just kind of messed up. It's really sick. And so like here, you don't have a progressive lengthening of the PR intervals. What you have instead is you'll have the kind of uniform PR intervals with QRS complexes which are dropped kind of out of nowhere. And so you're going to see lonely P waves which appear kind of randomly. And so you do not have a progressive lengthening of the PR interval. You have to treat this with a pacemaker given the risk of degeneration into third degree heart block or even asystole. Third degree heart block, this is very serious. Usually patients are going to present with serious symptoms. They may look kind of like a pallid. They may be hypotensive. They may even have their cardiac arrest. They may be this may be in a code situation. This is usually very bad news. So this is where the ventricles and the atria are depolarizing, contracting independently of one another. And so there is no communication between the atria and the ventricles in this condition. So what's going to happen is, the atria are going to fire at their own rate, and the ventricles are going to fire at their own rate, and there's going to be no synchrony or kind of matchup between the two. So what you're going to look for on the EKG is a uniform P to P interval and a uniform R to R interval, but no matchup between those two. So that's going to be third degree heart block. Definitely need to go for a pacemaker in this case. Very serious condition.
Beautifully said. Do you mind taking us through this first case, Dave? Sure.
Okay. So once again, following our algorithm, we start with the heart rate. And so the heart rate's kind of hard to estimate in this case. I think there are 9 large boxes between the QRS intervals. So 300 divided by 9. I'm not the best at math. Somewhere, very, somewhere in the range of maybe 50, 40, somewhere around there. So not high at all, right? So, okay, now, actually, hang on, sorry, 30, so somewhere around 30. Okay, so we have the rate. So this is a bradycardia. This is a bradycardia, which means either sinus bradycardia or heart block. To rule out sinus bradycardia, which lead do we say we look at first to assess whether the patient's in a sinus rhythm or not? Which lead? Excellent. Everyone's saying 2. Perfect. Yes. Okay, so we go to lead 2 and we ask, is there a P followed by a Q, like a QRS complex, and vice versa, or is there not? And the answer seems to be no, not really, no. Okay, so we suspect heart block. Now we have to establish what kind of heart block. And this is where things can get kind of messy. So what I like to do when I'm assessing like whether there's a second degree heart block, third degree heart block is I'll kind of like what I'll try to look for first is the PR intervals. So looking at a rhythm strip, down at V1, do we get like some sort of idea of what the PR intervals are like? Are the PR intervals are they changing? Are they the same? Like what are they? Or do you not really see a pattern here? Okay, seeing same. Okay, dropped QRS, long PR. Okay. Okay, let me ask it this way. As we said, in third degree heart block, the atria and the ventricles are depolarizing independently of one another. So do we see a regular P to P interval, like P wave to P wave interval? Yes, I'm seeing some yeses and some nos. Actually, we do, but it's kind of tricky because every now and then the P waves can be buried in the QRS complexes or in the T waves. So you really have to search. Yes, tiny. Yes, it is tiny. You have to search for them. But like, if you do find them, you'll notice that they actually are kind of like buried in there. So are the QRS complexes, are they occurring in regular intervals? Yes. Okay. So what is our diagnosis? Third degree heart block, right? Good.
Wonderful. The other clue that I would give, because this is challenging, I'm not going to lie to all of you, this is really challenging, is sometimes if the P wave is buried within the QRS or the T wave, you'll notice that there's like a funny looking QRS complex, or the T wave suddenly looks a little different. And that's because you have that superposition of the regular atrial rate on top of that happens to coincide with a regular QRS. The ways people get tripped up. One is that sometimes it just happens to look like a QRS is followed by, or a QRS is preceded by a P, or that it's lengthening. But it's not. But that's a fake association. It's not an association that's physiologic because of the conduction system. It's simply happenstance that because of how the math works out with the rates in the two chambers, occasionally it's going to look like something is conducting. Occasionally it's going to look like maybe a PR interval is widening in two subsequent beats. But what Dave said is spot on. You want to see, is it regular in the atria? Is it regular in the ventricles? Are they independent? If so, you are dealing with a third degree heart block. We'll have another example of this, but here is another example. Take a moment to look at this strip. And as you all are thinking, it looks a little bit irregular to me, just eyeballing it. But again, we focus in on 2, looking for those P waves. And even if I look in 2, if I look in V1, I'm seeing a P before most QRSs. It's pretty consistent. I will point out that there's one beat here that's a little irregular. And sometimes if you see one isolated beat that isn't quite matching up with the others, it could be what we call a PAC, or if the QRS is wide, a PVC. Beyond the scope of the exam, don't worry about it. For this rhythm strip, we're just going to ignore it. We're going to pretend that this is regular. But what you will notice is, remember that 200 number for PR, right? Each little one is 40. So we're talking about, 3, 4 sort of small boxes, more 4 or 5 actually. But here it looks long. So if I were to tell you this is a P before every QRS, but it's a little bit long, what kind of heart block would we be describing? I'm already seeing one correct answer. Beautiful. So this is a sinus bradycardia because the signal is still coming from the right place in the atria, right? Upright in 2, but it's just taking a little bit of extra time for that signal to traverse through the AV node and into the ventricles. Phenomenal job. Here's another, actually, we're going to wrap up with some quick rhythm strips. Again, it's all about the reps. First up.
Yeah, so sometimes on the exam, they're going to give you a full 12 EKG, and sometimes they're just going to give you a little strip like this. So it is good to practice on little strips like this. So starting with our rate. At a first glance, the QRS intervals look pretty regular. And so we can go ahead and safely use our 300 rule. And so it looks like they're about maybe a little around 2 big boxes between the QRS complexes. And so we're going to say our rate is around 150. So yes, we are dealing with a tachycardia. Okay, so we have a tachycardia. Now, rhythm. Do we see anything here which indicates that the patient could not be in sinus rhythm? Any changes to the P, any abnormal P waves or no P waves, things like that? Yeah, I'm seeing no. So actually, yeah, we actually do have P waves, and we do have T waves as well. Now, in this case, since we have a tachycardia, they're kind of overlapping a little bit, and so you get this sort of like a camel's hump morphology. But this is actually just good old-fashioned sinus tachycardia. There's nothing unusual here, which kind of leads us down a different route. We have narrow QRS complexes. We have a P wave that's always followed by a QRS complex. All of our QRS complexes are preceded by P waves, and we have T waves. Yes, they kind of overlap with the P waves a little bit, but we can make the diagnosis of sinus tachycardia because there's nothing else to lead us in a different direction.
Beautiful. And I agree with someone in the chat that it does look a little smushed, but remember, there's only so much time that can elapse between ventricular repolarization and the next atrial depolarization. And so the morphology can look a little funny. Typically in A flutter, there's more of that sawtooth appearance, particularly on the exam. They're going to give you classic examples of classic physiology. The point here is not, you're not an electrophysiologist taking the EP boards. You're a med student taking an examination meant for general medical students. Here's another example, pretty classic, right? We look at the rate, and I'm tempted to use the big box method, but I start noticing that I'm not sure which QRS is to pick because it's a little irregular. So then I ask myself, do I see any P waves? And I'm staring at the intervals between the QRS complexes, and I'm having a tough time picking anything out. Sure, maybe you could convince yourself this is a P wave, but it sort of can't be distinguished from the preceding 2 squiggles. And in the next interval, the amplitude's all different. I'm already seeing the correct answer in the chat. I'm going to give you all 5 more seconds. What is an irregularly irregular tachycardia? I'm seeing atrial fibrillation. And I just put the example here of another irregularly irregular tachycardia. But in this case, I'm more able to convince myself that there are P waves. The P waves all just look kind of funny. And this would be multifocal atrial tachycardia. Again, looking for 3 or more distinct P wave morphologies.
Well, if I could add something to keep in mind about AFib. So with AFib, on AFib on the wards, you can actually distinguish between kind of different patterns of AFib. So there's coarse AFib and there's fine AFib. On the exam, I really don't think they're going to ask you to distinguish between these in the answer choices. But the point is, coarse AFib, the kind of atrial activity that has a higher amplitude. So it can actually look like you have a bunch of P waves kind of back to back. But don't take the bait. Don't take the bait. If it's an irregular rhythm, and the patient has no kind of clear P wave morphology, then that's probably going to be atrial fibrillation. Don't fall for things that kind of look like P waves. Yes, it may be matte, but probably if it's irregularly regular, and there's no clear P waves at all, that's going to be atrial fibrillation.
Common things being common, absolutely true.
Okay. This one's tricky. Okay, again, so rate, starting off, I don't know precisely how long this little strip is. Let's say it's about 10 seconds. So, we have 1, 2, 3, 4, 5, 5 or 6 beats per 10 seconds. This is gonna be a bradycardia, right? So we're dealing with a bradycardia. So once again, we have it down to sinus bradycardia or heart block. So question number 1, is this sinus bradycardia? And the answer seems to be no, since we do not have QRS complexes after all of our P waves, and so we can get rid of that. So we're on to heart block. This is definitely not just 1st degree heart block. We have a lot more going on than just PR prolongation. So we have it down to 2nd degree and 3rd degree. So So a few things we can consider here. Does the PR interval, okay, so first of all, do most of the Q waves, QRS complexes, are they preceded by P waves? Is there some sort of relationship between the P waves and the QRS complexes? Or are they kind of off doing their own thing? Some missing P waves. Yes, yeah. Own thing. So actually, there is a relationship between the P waves and the QRS complexes. What we see is the first two QRS complexes on the left, those are actually preceded immediately by P waves with a pretty uniform PR interval. And then the three QRS complexes on the right, once again, we notice that all of those are preceded by P waves. So there actually does seem to be some sort of relationship between atrial depolarization and ventricular depolarization. But we do not have PR interval prolongation. So we've gotten rid of complete heart block since there is a relationship, and there's no PR prolongation. So we're left with Mobitz type 2 second degree AV block, where we have kind of randomly dropped beats with kind of lonely P waves sitting by themselves. But the important point here, and which allows you to distinguish this from complete heart block, is there is a clear relationship between the P waves and the QRS complexes. Even if there are some dropped QRS complexes, there is still that relationship. So this is not complete heart block.
Beautiful. And then just attacking it from the other direction, I would just add that here there is no independent ventricular rate, right? You can see that every QRS is coupled to the P wave, as opposed to third degree heart block, where the QRSs would be marching out at their own independent ventricular rate. So here's another example. This one should be quick because we've actually seen this before. So quickly in the chat, what do you all see in this particular rhythm strip? And I'm already seeing VTAC, I'm seeing mono VTAC. That's absolutely right. Again, the differential here would include things like acute ischemia, things like SCAR. Again, the polymorphic, monomorphic thing, probably beyond step one. But here what you're seeing is, just to go through the algorithm, tachycardia, right? You see two big bodies. This is at least 150, roughly 150 beats per minute. There's no clear P wave. It's a wide complex. So we're thinking ventricular tachycardia. Okay.
This one, again, is more a matter of pattern recognition than anything else. So still, I like to follow our algorithm just to practice it and to make sure we have it down well. So rate, the QRS complexes are occurring at regular intervals. There seem to be about 5 boxes between them. And so that would give us a rate of around 60, which is appropriate. Maybe kind of borderline bradycardic, hard to say. But we do see a kind of distinctive a distinctive kind of rhythm pattern here. Yeah, it seems like everyone pretty consistently is getting this one. Yeah, this is your classic sawtoothing with atrial flutter. So yes, very good, very good. Yeah, as you see more and more EKGs or more and more strips over time, it will get a lot easier. And you will reach a point where you can simply kind of look at a rhythm strip and immediately make your diagnosis. Now, you still always want to read the vignette, make sure you've incorporated your EKG findings into the information already presented by the vignette to make sure that your EKG makes sense. But oftentimes you will be able to make a reflexive diagnosis if you've practiced these enough.
Excellent point.
Yes, yeah, there's an excellent question in the chat. Atrial flutter can have a low heart rate too. Yes, it actually can. The heart rate in atrial flutter is determined by how many of those atrial depolarizations make it through the AV node. And so, patients like this patient, for example, maybe they were diagnosed with atrial flutter last week and they were started on a beta blocker. That beta blocker is going to make it harder for those depolarization waves to travel through the AV node. And so it's going to slow down the heart rate. So yes, atrial flutter can have a lower heart rate, not always going to be tachycardic.
And actually, that's a great point to generalize, because atrial fibrillation can also have normal heart rates, or even in some cases, slow heart rates. The principle here is how intact and what is the AV node doing, right? Is it letting every second pulse of that electrical wave through, or is it being a little bit more restrictive, and that determines your heart rate, both in atrial fibrillation and in atrial flutter? So phenomenal question and a great point to make. We have one more example for you all to cut your teeth on. Again, the last few have been reviews. This is something we've seen before. And already folks are out the gate with some phenomenal suggestions. So let's say that this was bradycardia, right? The first step in bradycardia is to look at that P wave, look at that QRS, and assess if there is some sort of relationship. So let's start with the P waves. I see one here, 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 here. And it looks sort of like a regular P wave. The P waves are occurring at a regular sort of interval. So that's the first thing to note. I'm also noting that the P waves are showing up in some funny places too, like a QRS complex, and then immediately after that, a P wave. But okay, we'll file that for later. Next, we're looking at the QRSs. Again, just eyeballing it, it looks fairly regular. So I have P waves that are going at their own rate. We have QRSs, again, going at their own rate. Folks are already saying this is third degree heart block. And you can see that the QRS complex often looks a little different from beat to beat. So yes, this is third degree AV block, distinguished from second degree AV block, again, by the relationship between the P and the QRS complexes. Here, the QRS complexes are marching along at their own beat because they're not receiving the signal from the atria as to when they should contract. They have to generate that signal on their own. And incidentally, in this case, you're also seeing a wide QRS complex as a result. All right, so I want to take a step back and really give you a roadmap of what we talked about today. First, and something David has been really emphasizing throughout, is the need to have an approach. And this is particularly important when you get to a question and you don't know quite what's going on. Don't panic in those moments. You know more than you think. If there's an EKG involved, it's a cardiology case, and you don't quite know what's going on, go back to the tried and true algorithm, thinking about the rate, fast, slow, thinking about the rhythm, is it sinus, is it not, thinking about the axis and whether that tells you anything about the diagnosis, looking at those intervals so you don't miss a critical diagnosis, as well as the morphology. All of this is critical because the EKG is a hypothesis testing tool. Likely you're going to be reading a vignette, already have a differential in your mind, and you're looking to the EKG to raise the probability that your suspicion is correct or to lower the suspicion that your diagnosis is correct. If the patient is presenting with chest pain and you think that this might be an MI, but you see no ST elevations, totally normal ST segments, but instead you see that they're tachycardic, maybe in the vignette they're a little hypoxic, maybe you see an S1Q3T3, big buzzword there, what would you be thinking in that case? Put it in the chat. Yeah, folks are saying a pulmonary embolism. So you're using the EKG to help guide your differential diagnosis. And then we went through two big buckets, the two fasts and the two slows. We talked about the algorithm for a tachyarrhythmia, which involves thinking about whether it's wide complex or narrow complex, and additionally, whether it's regular or irregular, as well as bradyarrhythmias, where the name of the game is really to understand and tease apart what is the relationship between the P waves and the QRS complexes, both in sort of a qualitative way, whether they're coupled or not, but also in a sort of quantitative way. Is it too long, right? Or is it that there's no relationship there at all, which would really point towards a third degree heart block? Anything to add here, pearls, that you would pass along to the students?
No, not a whole lot. So I think it is worth mentioning that you may have EKG abnormalities which are neither a bradyarrhythmia or a tachyarrhythmia. So like the patient may have a normal heart rate, and like we saw some examples of that, like where you could have things like atrial flutter. That, for example, could have a normal heart rate. Things like like PVCs, PACs, sinus arrhythmia. Those can all have a normal rate. So like the extent or the range of pathologies you might see in your exam presented in an EKG goes beyond this. But like a good many of the questions you're going to get involving an EKG are going to have either tachycardia or bradycardia. And so as long as you're taking your algorithmic approach, like even if you like don't know what the exact rhythm is, like if you take your you start with the rate, you go to then see if you can make sense of the rhythm, check your axis, that sort of thing. Like even if you can't get all the way to the right answer, you can oftentimes eliminate 2 or 3 answer choices, which will drastically increase your chances of getting the question right.
Beautiful. So again, just to wrap up the formal part of this presentation, to remind you who we are at MST and how we might extend your learning, really help you achieve your goals. A lot of what we do is one-on-one tutoring, which includes, the keyword here is customization and personalization to really help you get through whatever roadblock is facing you in terms of your examinations or applications. Both David and I have tutored many students and from a variety of backgrounds from all over the world. And really, we are here to help you. In addition, there are a variety of other opportunities for us to interact in terms of one-time strategic planning sessions, consulting around ERAS, interview prep. Unfortunately, in the forum of a webinar, it's impossible for us to really address your specific situation, but the contact information down there is below: social media, email, phone number. Please don't suffer in silence. Med school and the whole process is incredibly stressful, but one of the beauties of medicine is that we're a community of people who care about others and who really want to succeed together. And so we want to be a part of that for you. And with that, we've pretty much at the hour, but I promised that we would have a few moments for questions at the end. I apologize if we didn't get to your question during the formal presentation. We were too busy nerding out over EKGs. And if you're raising your hand, again, sometimes we can't address that as the presentation proceeded. Please put those questions in the chat. That's the best way for us to see what your question might be. So with that, I'm going to stop the presentation. Please take the next 60 seconds to put a question in the chat and we'll address it if we can. I see one question so far, and that is around the question of, do all QRS show delta wave in WPW? Let me put it to you this way. If we're talking about the step 1 examination, the delta wave is going to be obvious. It's not going to be some tricky, super subtle delta wave. You're going to be able to see it with ease. So it's going to be an obvious slurring with the associated vignette.
Yeah, just to kind of further emphasize that point, to emphasize the excellent point that Moses made earlier. Like they really do not expect you to be cardiologists in training, EP fellows. If they're going to give you an abnormality on the EKG, it should be more or less obvious. It's going to be a textbook case. When you get onto the wards and you're analyzing these EKGs for all your patients, you begin to appreciate that there's a lot of nuance and complication to reading an EKG. They're not going for that on this exam. They're just going to give you the textbook cases because they know that you are not, you are not a third-year internal medicine, third-year medicine resident. You're not a cardiology fellow. You're not an EP fellow. So they're going to keep things nice and simple.
Awesome. There's another question here: Mobitz 1 versus Mobitz 2. David, do you want to take a crack at answering that, and I'll chime in as well?
Sure. So the question is, why is Mobitz 1 not Mobitz 2? Is that am I understanding the question correctly?
I think so. And maybe I'll just kick it off by saying, what even is the difference between Mobitz 1 and Mobitz 2? I'd love to hear what you have to say, David, but in my mind, the question really is, are there P's that aren't followed by QRS complexes? And then you can tease apart which exact one it is by then thinking about whether there's complete independence in which you're in third degree land, whether there's a missing QRS and there was preceding prolongation of the PR interval, right, which would be more of a type 1, or whether it appears sort of random without a change in the PR interval, which would make it more of a type 2.
Yes, yeah. Yeah, a couple of clues that can specifically help you to differentiate type 1 second degree AV block from type 2 AV block or second degree AV block is, again, with type 1, you want to be on the lookout for PR intervals that progressively lengthen. Your PR intervals should be pretty uniform in Mobitz type 2. Also, Mobitz type 2 oftentimes is going to have a wide QRS complex. The reason for that is kind of complicated, not very important for the exams, but basically the blockage, like the blockage in the conduction system in Mobitz type 2, or sorry, in Mobitz 2, is usually below the level of the AV node, even below the level of the bundle of His. And so that means the ventricles are going to be setting their rate. And so oftentimes you have a wide QRS complex. But that's a little advanced. Usually you just want to look for progressive prolonging of the PR intervals. That's going to be your main clue.
Amazing. Thank you so much for those advanced pearls. I feel like even as a resident, I'm learning from you, David. So thank you so much. I don't see any other questions in the chat. Wait, someone just second degree. So just to address this up front, the fundamental idea of a wide QRS complex is that in the absence of the rapidly conducting, His-Purkinje system that ensures that most of the myocardium receives that electrical signal at the same time. In the absence of that, you see a wide QRS complex because it takes time for that electrical activity to move from the ventricle, because there's just so much more, it occupies so much more area, there's more mass, and so it takes time for that signal to travel. And that can happen in a variety of situations. It can happen when you have a bundled branch block. It can happen when you have blocks below the level of the AV node, just like David was saying. But you wouldn't expect it in something like a sinus bradycardia or something like a first degree AV block, because the level of the lesion is in a location that still preserves the simultaneous or near simultaneous sort of stimulation of the entire myocardium on the ventricular side. I will say that our time is really short, so I'm unable to sort of answer any further questions. I will refer you to a few resources just as we conclude. Life in the Fast Lane, if you just Google that, is an incredible online resource of EKGs with articles about every EKG abnormality you could ask for. Beth Israel Deaconess Medical Center has the WebMaven website where you can actually practice your own EKGs with feedback. And just like in this session, we emphasized your active participation as you study for the boards. The more EKGs you've been exposed to and you've worked through, the more likely you are to feel empowered when you face one on an examination. So with that, I really want to pause and wish you all the very, very best. Whatever stage of training you're at, whether your exam is a week from now or several months out, or it's really in another year of your medical training, we are here for you. We hope that this was informational and maybe a little bit fun. And with that, we will wish you good night.
Good night, everyone.